Hello. Today we're going to talk about kidney transplantation and all the basics that you need to know. These are my potential conflicts of interest, of which I think none are relevant to this talk. I made some learning goals for this talk of today. We will talk about causes of kidney failure. We will describe long-term survival, then about the drugs that are used for kidney transplantation, and also their downsides. So let's talk first about the causes of kidney failure. There are many causes of kidney failure, of which you see them depicted here. The most common are diabetes, hypertension, and atherosclerosis. It is good to know that people with kidney failure have a very poor prognosis. What you see here in the graph is on the horizontal axis the age of patient grouped into groups of 10 years. And on the vertical axis you see a logarithmic scale. So be cautious that young persons who have kidney failure have the same mortality risk as healthy 85-year-old patients. And you see that kidney transplantations are in between, but they still do not have the same prognosis as people without a kidney disease. So there's still room for improvement. Does that mean that everybody should get a kidney transplant and that everybody is a potential candidate? No, it's always an individual evaluation, and we do have some red lines of which we think that a person is absolutely not a transplant candidate. I put them here, and as you might appreciate, that when there is a severe infection or where there are malignancies, that severely impairs the health of a patient and that precludes a kidney transplantation. And also the others give a higher risk of complications. So it's always a matter of weighing the risk and benefits of a kidney transplantation, and that is what we especially do in our center to see if we can improve the health of our patient with kidney failure. Some facts about kidney transplantation. Here in the Netherlands we do about 1,000 to 1,100 kidney transplantations a year, of which we in the Erasmus do the most. Last year I think we did some 200 plus, and about half of these kidneys are done with a kidney from a living donor. And later on you will see that that will give the best results. Despite this quite high number of kidney transplantation, the wait list is increasing, as you can see in the lower graph. We've been to a low of about 500, but now we're back to more than 1,000 people on the waiting list at the end of last year. How about long-term results? Well, when you think about long-term, I think that long-term is 15 years or more. Especially if you get transplanted in your 40s or 50s, you want to live a normal life. But there's very little data about 15 years plus survival. Here in the table you see survival in the USA, in Europe, and in Australia and New Zealand. And what you can appreciate is that the survival, especially after a long time, is not near a normal survival. Most patients do lose their kidney after 15 years or even lose their life. So although a kidney transplantation is better than staying on dialysis, it's again not as good as we hope, and we still have room for improvement, and we should improve the outcomes. And which factors do influence these outcomes? Well, first of all, as you've also seen in the previous slide, the type of donor. If you have a kidney from a living donor, both your graft survival and the patient survival are much better. What you also see in the graph here is that age is a very important factor. If you are young, below 40 years, then after 10 years the chance of you being still alive is more than 90%, which greatly differs if you are 75, for example. But then again, still 75-year-old patients have a better outcome after kidney transplantation than staying on dialysis. Of course, this kidney is not your own kidney, and your body will see it as an intruder and will try to get rid of it. So we need immunosuppressive drugs to maintain the health of this kidney. And then is the question, what is the standard of immunosuppression? And in kidney transplantation, that is tacrolimus, CellCept and prednisone. And it's also used in other organs, but what differs here is mostly the level of these drugs. And this drug regimen that we now have, of these 3 drugs, it comes from a long line of many trials that have been done, experiments starting in the previous century, in the 30s and 40s, and that was a time where we were just experimenting and seeing what works and what didn't work. And then finally we came up with these drugs. But what you also can see in the lower part of the slide is that after the 1990s or the 2000s, not much has really changed. Yes, in the 2010s we got belatacept, but this drug is still only used for a small minority of patients. As you can also appreciate in this data, this is data from Australia and from New Zealand, more than 95% of kidney transplantations receive this combination of tacrolimus, of mycophenolate, of CellCept and steroid. And that is reasonable because it's such a good combination. But on the other hand, as you can see here, I depicted some of the side effects of prednisone, of tacrolimus, of the mycophenolate mofetil. And you see that this powerful combination has also a combination of side effects. And there are patients who do not experience any side effects. On the other hand, there are also patients who have almost all these side effects. And unfortunately, we cannot do it without these drugs. If you notice closely, then you see on the previous slide that one of the side effects of tacrolimus is kidney damage. Now, how sour is that you waited for a few years on a precious kidney and then kidney function is lost to tacrolimus? It is absolutely true, as you can see in the picture below. These are rat glomeruli, and rats were fed cyclosporin. That you see that these glomeruli are completely constricted. So the kidney cannot function normal when people use this drug. And if you do biopsies after 10 years, you can see in everybody damage to the kidney. Why do we still use it? Again, because it's the most effective to prevent rejection and to maintain the health of the kidney. But for example, in lung transplantation and heart transplantation, we see a considerable loss of kidney function due to this drug. Other side effect of immunosuppressive drugs is that they also suppress the reaction against bacteria and against viruses. So we see more infections, we see different infections, and we see them at different time points. And the table here below is just some illustration of how different infections go through time. Another side effect is a higher risk of cancer, because your immune system also protects you against cancer, and if you lower that, the cancer incidence is higher, especially skin cancer. So prevention with screen blockers is absolutely crucial. Then to finish the complications, the risk of cardiovascular disease is extremely high, although it is lower than staying on dialysis. So every transplant patient, every kidney transplant patient should be treated as a high-risk cardiovascular patient with the appropriate medication. So with that, I want to conclude this talk. So with this, we come to the conclusion of our talks. We talked about causes of kidney failure, for example, diabetes or hypertension and atherosclerosis. Long-term survival is still poor, with most patients after 15 years having still their kidney, but also a significant portion of them already lost either their kidney or their lives. The 3 drugs that we use for kidney transplantation are tacrolimus, mycophenolate mofetil and steroids. They have a multiple side effects. They have also the negative effect of increasing the risk of infection and increasing the risk of cancer. Thank you very much.